All right, guys, how are you? How's everyone? Can you guys hear me okay? Yeah. Hello, Tamiko. Tamiko, can you hear me okay? Okay, awesome. Awesome. All right, guys, it's Friday night and we're here. Hi, Chris. All right, so let's read the FBI warning. Tonight, guys, is osteoporosis, osteoarthritis, and rheumatoid arthritis. All right, guys, so this is called fair use and is allowed for purposes of criticism, news reporting, teaching, and parody, which doesn't infringe of copyright under 17 USC 107. All right. So just so you guys know, the views, thoughts, and opinions expressed in the text belong solely to the author and not necessarily to the author's employer, organization, committee, or other group of individuals or individuals. All right, guys. So it's not a long lecture tonight, guys. A lot of images. So you guys can follow along and kind of put a visual representation to what I'm telling you guys about these three different system disorders. And remember, you always want to supplement your lectures with questions and videos. So osmosis.org is very good. Registered Nurse RN is very good, but make sure you guys are using a concept map and do some Saunders questions after every lecture. All right, so let's go. So you have osteoarthritis and rheumatoid arthritis, and we're also going to talk about osteoporosis. So I kind of want you guys to focus on the joints. Okay, look at the normal joint and look at osteoarthritis. And now look at rheumatoid arthritis. Look at the debris in osteoarthritis. So I always remember osteoarthritis as wear and tear. All right, wear and tear. And then rheumatoid arthritis is an autoimmune. So you notice the inflammation is there, but not too much debris. So I want you to keep that in mind. All right. So the first system disorder will be osteoarthritis. Osteoarthritis will be our first system disorder. All right. So we're going to talk about the pathophysiology, but I'm not going to talk about too much pathophysiology because I want you guys to focus on nursing interventions because we're nurses. So you guys are either taking the exit exam or you're taking your NCLEX exam. So we're going to focus on nursing interventions and medications tonight. All right. So certain things I want you guys to remember about osteoarthritis is it's a progressive deterioration of the articular cartilage. So it progresses. The cartilage slowly deteriorates. All right. It's non-inflammatory. And I want you to really remember that it's non-systemic. Okay. Non-systemic. So you're not going to see a patient with a fever or fatigue. All right. It's non-systemic. It's very different from rheumatoid arthritis. And another thing I want you guys to write down is one-sided. One-sided. Okay. It's one-sided. And Giovanna, can you guys hear me? Oh, okay. Okay. Awesome. Okay. I'm just making sure. Okay. So I want you to remember, Giovanna, we're comparing osteoarthritis to rheumatoid arthritis because that's the heavy hitter. Okay, so it's non-inflammatory, non-systemic. So this patient won't have any fever or fatigue and is one-sided. Okay, that's a big difference when compared to rheumatoid arthritis. Rheumatoid arthritis is systemic. It's an autoimmune. All right. So health promotion and disease prevention. We're going to talk about how do we help our patients? How do we educate our patients? So health promotion and disease prevention. We're going to talk about body mechanics, have healthy body weight, and well-fitted shoes for osteoarthritis, okay? So here we go. Body mechanics, guys. Make sure that your patients throughout life, throughout our journey, that you're teaching them about good body mechanics, okay? Remember the ergonomic principles and encourage your clients to always maintain a healthy weight, okay? You want to make sure there's not as little weight on the joints, like the hips and the knee joints, as possible. So to decrease joint degeneration, teach your patient about a healthy weight. All right. So you want a health promotion and disease prevention, body mechanics, ergonomic principles, okay, and a healthy weight. The less weight that is on the hip and the knees, the less degeneration will occur. So I just want you guys to make sure that you're teaching your patients that. All right. Also, a big thing to promote for osteoarthritis is smoking cessation. So stop smoking. Don't start smoking. Avoid exercises that put repetitive strain on your knees, on your joints. So this is like jogging and contact sports. That's why you have a lot of people that were in the military, they suffer from osteoarthritis. All right. And shoes, guys. Recommend wearing well-fitted shoes because you want this patient to have the proper support to prevent any type of injuries. So well-fitted shoes. All right. This will make sure the patient has the support that he or she needs. And it helps prevent osteoarthritis, believe it or not. All right. So remember, just a quick recap. Health promotion and maintenance, guys. Smoking cessation. Tell the patient to stop smoking or don't start smoking. All right. And if they are smoking, make sure that there's, that you give them the information that they need to stop smoking. Ergonomic principles, guys. Teach your patients, especially guys, you guys are going to be working in nursing. You're going to be lifting patients, pulling patients. You have to protect yourself. So remember ergonomic principles so you're not suffering from osteoarthritis. All right. And you want to tell your patients always to maintain a healthy body weight. So the less stress on the joints like the hip and the knees, it will slow down the degeneration. So make sure that you are telling your patients these things to promote health. And don't forget the shoes. All right. If they're going to do these type of exercises, if you guys are going to be working on the nursing floor, you got to buy you some good shoes, some proper fitting shoes. Okay. All right. Just remember that. All right. So now let's talk about signs and symptoms of osteoarthritis. All right. So we're going to talk about joint pain, crepitus, inflammation, and enlarged joint. So osteoarthritis, these are the signs and symptoms of osteoarthritis. All right. So remember, guys, pain, pain, pain. All right. Pain, pain, pain. When the patient presents to you in your office or on your floor, they're going to complain of pain. They're going to say joint pain. They're going to say joint stiffness. Okay. They're going to say pain with joint palpitations. When you touch the joint, the patient is going to be in agonizing pain. All right. and crepitus. I want you to remember that. Crepitus. All right, because you can actually hear the crepitus. You'll hear the crepitus in the affected joint. All right, enlarged joint. And this is very important, guys. This is a sign and symptoms that's specific to osteoarthritis. So you have to remember this, okay? Herberdine's nodes and Bouchard nodes. Herberdine's nodes, Bouchard's nodes. Okay? And then we can't forget inflammation. So this is going to be, these are the signs and symptoms that your patient will present, the clinical manifestations of osteoarthritis. So the patient is going to come to you. Either he'll be on your med-surg floor, or you'll meet him in the ED, or you'll meet him in the doctor's office. The patient is going to complain of joint pain. You see the joints? So if you look at the hip, that's the reason why you want to tell the patient about healthy body weight. All right? The patient is going to complain of, or you'll visualize enlarged joints. Okay? Enlarged joints will be present. And very, 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 very important, the Herberdine's nodes. All right? This slide is extremely important, guys. You have to remember this. Herberdine nodes and Bouchard's nodes. So kind of just take a look at them, all right? Because this is a sign and symptom of osteoarthritis. You're not going to see this in rheumatoid arthritis, all right? So make sure that you guys know those nodes front and back, all right? They love to ask those questions on the NCLEX and also on your exit exams. So here's another visual for you. All right, Herberdine's nodes. So this is something that you'll visualize if the patient has osteoarthritis. All right, swollen joints. Swollen joints. All right, the patient will come in and complain of these swollen joints. You'll see it. All right, you'll be able to visualize it. So remember those signs and symptoms. Okay, and guys, believe it is a one-sided, it's a unilateral swelling, unilateral degeneration. All right, so just make sure that you keep that in mind also. So diagnostic procedures for osteoarthritis. What can you anticipate the doctor ordering? Well, he's going to order an ESR. You guys know that. He's going to order a CRP, X-rays, and CT scans. All right, this is what he'll use to diagnose osteoarthritis. All right. So at first you'll go there and you'll, as a nurse, you want to look for, if a patient is complaining of osteoarthritis and presenting like the system disorder osteoarthritis, you want to look at these diagnostic procedures. You want to make sure that the doctor has ordered these. Okay. So it's the ESR, the erythrocyte sedimentation rate. All right. And for the second empty spot, I want you guys to write down high sensitivity C reactive protein. High sensitivity C reactive protein. Okay. And of course, X-rays. And the fourth diagnostic procedure is CT scans. All right. So we have ESR, high sensitivity C reactive protein. We have X-rays and we have CT scans. All right. So as a nurse, you guys know that you are responsible for, to look at the results. You want to know if your patient is progressing or getting worse. All right. So these are some of the definitive diagnostic procedures that you can anticipate the doctor ordering if your patient does have osteoarthritis. All right. So remember, erythrocyte sedimentation rate, guys. All right. They're going to do CT scans. So you can actually see, like if you look at this picture here, you can actually see the degeneration happening. So they'll do a CT scan, all right, to give a definitive diagnosis. So I want you guys to remember those. Make sure you remember ESR and CRP, guys, for sure. All right, make sure you remember those. So nursing interventions, this is us, osteoarthritis. This is something that no one is going to tell you. There's no orders for nursing interventions. Some facilities are very good. They will populate it on your electronic health records, but the board wants to know, okay, this patient has osteoarthritis. Do you know how to intervene? Do you know what to do if your patient has osteoarthritis? So let's look at some of the things that you are responsible for as a nurse that no one is going to tell you to do. Okay? You have to know to do this specifically for someone who has osteoarthritis. All right? So, nursing interventions. Monitor pain and fatigue after activity. Okay? Monitor pain and fatigue after activity. And limitations. Monitor degree of functional limitations. Because you know, if your patient has osteoarthritis, he's not going to be able to do the things that he normally does. But you absolutely do not want this patient to decline. All right. Remember, we foster independence. Okay. Whatever they can do, we as a nurse, we advise them to do it. All right. So always monitor degree of functional limitations. And you want to monitor range of motion, guys. Okay. We don't want our patients to decline. So every little thing that they can do for themselves, we highly encourage it. All right. So we have to catch it. Okay. So also, nursing interventions. Look for proper joint alignment. Okay. You can't have a patient on the floor with you day after day after day, and you don't know if the patient no longer has a proper alignment of the joints. So, proper functional joint alignment. Proper functional joint alignment. You always have to assess your patient musculoskeletal function. So, this is one of the reasons why. And if the patient is home safety, because the patient does have limitation, and that's a huge deal. Safety and ADLs, guys. Can this patient still perform ADLs? That's a huge deal for nurses, guys. Because remember, we can't leave a patient in the home alone and the patient can't cook, bathe, toilet. So we have to monitor the ADLs for this patient. All right, so this is just something that you guys give you guys a visual. This is the normal bone, and this is osteoporosis, osteoporotic bone. All right, so we're going to talk about osteoporosis now. ADLs, I just gave you guys a visual because I think I had a group of students, they didn't really understand what ADLs are, guys. There's instrumental ADLs, guys, and there's ADLs. The one thing that I want you guys to remember about ADLs, just really quick, I want you guys to remember that if a patient can't cook or get a glass of water for himself, that patient is going to decline. You guys know, and you can type it in the chat, if you can't get your own water or your own food, then who else is going to get it for you? Really? All right. We pretty much have to take care of ourselves. And when we can't get something like a glass of water, guys, or cook or toilet, that's when we start to decline. So if you have any patient that has any functional limitations, guys, remember our priority is to assess the ADLs, because we may have to get a referral for HHA or a CNA for this patient. We can't have a patient at home, wet in the bed, smelling like urine, not being able to cook a meal, not being able to order a meal. So as nurses, guys, this is our priority. So these are some ADLs. You have bathing, ambulation, toileting, dressing, eating, transfers. So this is ADL. Just in case you guys haven't worked as a CNA, just remember that this is very important for as a nurse that we need to assess. All right, because we can't leave a patient that can't do these things. We may have to refer the patient or have the physician to refer a HHA or a CNA. All right. Pain and fatigue. All right. If a patient, we have to monitor pain and fatigue after activity. All right. Monitor pain and fatigue. Okay. After activities for our patients, this is one way that we take care of our patients. All right. So now we're going to discuss meds. All right. What type of medication can you anticipate seeing on the medication administration record for someone who has osteoarthritis, guys? You are definitely going to see acetaminophen. You're going to see NSAIDs. You're going to see capsaicin. And you may see hormone replacement therapy. All right. So all of these medications, so you guys know the deal with meds, the 6 rights of medication administration every time you pass a medication, guys. All right. So you're definitely going to see acetaminophen. That's Tylenol. All right. Just remember the max, guys, is 4,000 milligrams a day. You cannot go over 4,000 milligrams a day because you're going to ruin the patient's liver. So you have to know that, and you have to make sure that the patient is aware of that also. All right. So NSAIDs. All right. This is our naproxen, our ibuprofen. Guys, even though this is over the counter, guess what? We still have to monitor the BUN and creatinine. Okay, we still have to monitor the BUN and creatinine. NSAIDs are nephrotoxic, guys. They will ruin the kidneys. Okay, so if you see that your patient has osteoarthritis, they've probably been on NSAIDs for a long term. So monitor the BUN and creatinine. All right. Teach the client to report black tarry stools, the melena, M-E-L-E-N-A, melena. You guys know that that means the patient is bleeding, a GI bleed. Okay, melena. The patient may have like gas, indigestion, and the patient may become short of breath. So if they're taking these NSAIDs, guys, even though you can get them over the counter, they still have their adverse effects. So educate the patient. So the patient will tell you if they see these things. All right. So some patients, guys, when you go to home health, they don't want these NSAIDs because they know the side effects. So they want something topical. All right. So topical analgesics. So they may have the capsaicin. They may ask for that because you can just rub that on your knee. Glucosamine, they call that joint juice. You can get that from like the BJ's or anywhere. Costco, they call it joint juice. Or the patient may have to resort to intra-articular injections. All right. That's also a different form of medication therapy for the patient. So all of these, topical, capsaicin, glucosamine, and the injections. So you have the hormone replacement therapy, guys, is also something that you can anticipate the doctor ordering. Maybe. All right. And if so, guys, just remember there's a lot of side effects to the hormone replacement therapy, guys, for women. All right. So remember medications. These patients may be on acetaminophen or NSAIDs. All right, acetaminophen, 4,000 milligrams a day, guys. 4,000 milligrams a day. Checking the liver function test if the patient is on long-term use of acetaminophen, because you know that this can destroy the liver. Okay. All right, so ibuprofen. So this is something that you guys can find over the counter. Make sure that you're monitoring the BUN and creatinine for the patient, BUN and creatinine, and let the patient know about GI bleeds, guys, indigestion, shortness of breath, because this is a side effect of these medications. So remember ibuprofen, BUN and creatinine, the kidneys. Okay. Even though it's over the counter, we still need to monitor. Celebrex. No one that has any type of cardiovascular issues, if they're going to take Celebrex, guys, they cannot have a history of an MI. Okay. If they, you have to make sure that you ask the patient, Do you have any cardiovascular issues? Do you have a history of myocardial infarctions? Okay. It's contraindicated. So make sure that you guys remember that. And of course, BUN, creatinine. If you're going to give these patients these long-term NSAIDs, guys, even though it's over the counter, it can still destroy the kidneys. So as a nurse, if you know that that patient has been on these medications for a long time for osteoarthritis, you have to say, well, let me pull a lab. Let me ask the physician if he can get a lab, you know, if we can draw a lab for you before I administer this medication, just to make sure. And remember that these medications are nephrotoxic. All right. The medications, they will destroy the kidney. All right. So that BUN and creatinine is extremely important. All right. Make sure that you guys remember that. And tell the patient to tell you if they have black tarry stools. Black tarry stools, that's the melena. Okay. Make sure, because that's an indication of the GI bleed. And you guys know that these NSAIDs can cause a GI bleed. So make sure that you're telling the patient that. And the capsaicin, guys, this is a topical medication. It's derived from these red peppers. I mean, it can get, I saw a couple of videos on it. It can get extremely hot, but the patients oftentimes they request these the capsaicin. All right. So it's definitely something that I saw a lot in home health. A lot of the patients, they want the capsaicin because they don't want the NSAIDs they don't want acetaminophen because it'll destroy the liver. And they don't want the NSAIDs because of the indigestion. The Celebrex, definitely if they've had an MI, they don't want the Celebrex. So a lot of a patient will just prefer topical medications. All right. So this is the glucosamine. This is something that you'll hear a lot. They call it joint juice. A lot of people, they'll eat the bones, the chicken bones. They say it's in the bone. I forgot the name, the marrow, the bone marrow of a chicken bone. So they'll eat the entire bone. And they say it's very good for your joints to kind of health promotion and prevention of osteoarthritis. And the last resort, guys, well, not the last resort. They'll do intra-articular injections also to provide the patient with some relief. Intra-articular injections. So sometimes you'll see a lot of athletes get this. They'll get that shot and then they'll go right back into the game. So intra-articular injections also is something that you can anticipate the doctor ordering if the patient is suffering long term. And you can kind of look at this picture here to tell where they'll inject the patient. All right, so surgical now. Now we're in the last resort. Surgical intervention. So total joint arthroplasty. After all of that, guys, the patient is still having issues, still having difficulty, they're going to do total joint arthroplasty. They're going to replace it. All right. After the medications, after the patient has lost the weight, the patient is doing the proper body mechanics, the patient is taking the medications or the injections. But if none of that is providing the patient with any type of a relief, they're going to do a total joint arthroplasty. And you guys can kind of see it here. Will they replace the hip? All right. So remember, they'll do a total joint arthroplasty. The patient actually has to have surgery. And you guys know if you're taking care of this patient, we want to prevent DVTs. We want to get the patient up and moving, hydrate the patient. All right. So just another visual, guys. What are we discussing? We're talking about the differences between a normal joint, someone that has osteoarthritis, and someone who has rheumatoid arthritis. So remember, look at rheumatoid arthritis now. You see that? The inflammation It's an autoimmune disorder, but very little debris. But look at osteoarthritis. It's wear and tear. It's a wear and tear. So we have to do a lot of teaching with osteoarthritis. All right. So now let's compare it now to osteoporosis. Osteoporosis. Let's talk about osteoporosis now. All right. A little pathophysiology. Okay. Osteoporosis, guys, common metabolic bone disorder. It's a common metabolic bone disorder, and it results in low bone density. All right. Low bone density, osteoporosis, poor porosis. All right. So here's a little visual for you guys for osteoporosis. It's basically, guys, when the rate of bone resorption. So look at bone resorption on this picture. When the bone resorption exceeds the rate of bone formation. So resorption exceeds formation. So that's why they have bone destruction. Okay. Because the resorption exceeds the bone formation. So this patient is going to have brittle bones. Okay. The patient is going to have brittle bones. So the bone mineral density, guys, peaks at approximately the age of 18 to 30. After 30, it decreases. The bone density decreases. So it kind of puts you in trouble if you have a certain risk factors. So automatically, every one of us, right? It's approximately the ages of 18 to 30, bone density is going to decrease. But there's some individuals, guys, the risk factors are very high. So they have a higher chance of, succumbing or being affected by osteoporosis. Some people, risk factors are very high. Okay. Say, for instance, a postmenopausal woman, her risk factors increase for osteoporosis. This is the woman that we constantly educating, because you and I know her risk factors are very high. All right. So postmenopausal women due to estrogen loss. I know for a fact this is the population that I need to tell about osteoporosis. She's at risk for osteoporosis. All right. Also, there's others. All right. Other people, and we're going to discuss it. We have to promote health promotion. So for this one, I put use your health promotion worksheet. All right. So what are we going to promote for this woman who is maybe genetically predisposed, maybe lives a sedentary lifestyle, maybe she's not getting enough calcium and vitamin D? I want to make sure that I'm telling her, listen, before the age of 35, okay, your risk factors are very high. Please have a adequate amount of calcium and vitamin D in your diet. Okay? Calcium and vitamin D. Calcium and vitamin D, guys, okay? All right, you can encourage the patient to take vitamin D supplements, because if a lot of people, like such as myself, I'm lactose intolerant, so I have to take vitamin D. Okay? I'm 21 now, so I don't have, I still have time to, get my calcium and vitamin D, because I'm 21 years old. So, but when I'm 35, okay, I have to make sure that I'm getting the proper amount of calcium, I'm getting the proper amount of vitamin D. So when I do turn 35, all right. So yeah, I'm just playing, but just make sure you guys remember calcium and vitamin D. Tamika say me too. Get your calcium and vitamin D, guys, okay? So when you do turn 35, then you'll be covered. All right, but remember that, guys, because for some reason, we always want to remember vitamin C and vitamin D. No. Calcium and vitamin D. Calcium and vitamin D for health promotion and maintenance for osteoporosis. Calcium and vitamin D. All right. We also want to promote, all right, the sun, guys, exposure to the sun. All right. Expose areas of skin to sun 5 to 35 minutes twice a week. Okay, it helps. Okay, and hormone replacement, positive and negative effects. Let the patient know who has osteoporosis the positive and negative effects of hormone replacement therapy, guys. Okay, so that's kind of tricky. All right. You want to encourage the client to discuss the pros and cons of hormone replacement therapy postmenopausal with her provider, because remember, she's at risk. We're at risk postmenopausal. We are at risk. So we have to talk about hormone replacement therapy because there are plenty of side effects for hormone replacement therapy. And I put them earlier into the slides. All right. And most important, guys, weight bearing exercises. Encourage weight bearing exercise, guys, to prevent osteoporosis. All right. Some of us, guys, are just genetically predisposed. All right. It doesn't really matter what we do. We're genetically predisposed to these conditions. So you definitely want to identify female history, family history of osteoporosis, someone who's very thin, lean body. Okay. So thin, lean body build, family history of osteoporosis, female, they're genetically predisposed, and postmenopausal women. All right. If a woman has an estrogen deficiency, or if a man has a testosterone, low testosterone in males, so they're at risk. So I'll say it again, okay? Testosterone deficiency in males, estrogen deficiency in women. And for those that are considered genetically predisposed, they have a family history, they're female gender, very thin, lean body build. So this is the population that we want to educate about osteoporosis. All right. Also, risk factors for osteoporosis. This is someone who has a very, very low calcium and vitamin D intake. All right. Low calcium, low vitamin D. So if you're lactose intolerant, it kind of puts you at risk. And sometimes we avoid the sun. All right. So low calcium, low vitamin D. History of smoking, history of high alcohol intake, and believe it or not, excessive caffeine consumption. All right. So this puts you at risk for osteoporosis. So make sure that you're educating this population, guys. Make sure that they know what puts them at risk. Sedentary lifestyle also. All right. Hyperparathyroidism. And we're always talking about steroids, how effective steroids are. But steroids can cause problems, guys. And osteoporosis is one of them. So I really want you to focus on this corticosteroid, okay? Because you will get that on your exit. I can assure you of that. Corticosteroid, make sure that you do your concept map for that. So if a patient is on long-term steroid use, osteoporosis is a risk factor. Phenytoin, phenobarbital, these are our anticonvulsant medications. So long-term use of anticonvulsant medications. And you guys know that kids take anticonvulsant. It's life term, long term. For life, you take anticonvulsants. So this patient is definitely at risk for osteoporosis because you guys know we can't stop taking anticonvulsants. So imagine how long they've been taking these medications. So this patient is definitely at risk. And just overall lack of weight-bearing activity. So this puts our patients at risk for osteoporosis. So how do I know? What are the signs and symptoms of osteoporosis? Well, the patient will have reduced height or complain of reduced height or report reduced height. Fractures. That's normally what happens, guys. They fall at home and then they'll go in for the fall and they'll also be diagnosed for osteoporosis. And kyphosis. Remember kyphosis? That's the thoracic spine curvature. Thoracic. And those are some signs and symptoms that you guys will, probably see. You'll also see like some restriction in movement and spinal deformities. Also, guys, it can get kind of severe, and pain. So reduce height, fractures, guys, kyphosis, fractures, restriction in movement. So I want you to make sure you know that. So interventions, how do we intervene as nurses? What can you do as a nurse? All right. What can you do? Well, you want to make sure that you educate your patient about biphosphonates. Biphosphates. No, I said it right. Biphosphonates, guys. I put biphosphates here, but it's biphosphonates. All right. Calcium supplements, of course. And as a nurse, if we see these medications on the MAR, this is definitely something that we want to educate our patients about. Our biphosphonates, calcium supplements. This is something that we want. If they say, well, I refuse, we'll have to kind of just tell them, listen, this is for your osteoporosis. You really need this. All right. And then you want to educate your patient about dietary calcium foods. You want to tell them about magnesium, things like that. Educate the patient on all type of calcium supplements. So that's our role as a nurse. Assistive devices, guys. Make sure if your patient does suffer from a fall, that they know how to use the assistive devices. All right. When we had skills lab together, remember I had you guys going up the stairs with the cane, with the crutches and the walker. And I know you guys were mad at me, but I want you guys to know how to educate your patient on these assistive devices. Home safety is a huge issue, and sunlight exposure. Okay. They don't have to do like strenuous activity, but you definitely want the sunlight to get to the skin. Now, what's gonna happen, guys? If the medications, the diet, the weight bearing activity is not enough, they have to do surgical interventions, especially if the patient has a fall. So you can anticipate the physician ordering joint repair or joint arthroplasty for this patient. All right. So just a brief recap, guys. Look at osteoporosis. Just kind of take a look at it. You can see the pores, the bones with osteoporosis is a different bone matrix. All right. Remember, guys, 18 to 30, that's our peak. After that, 18 to 30, that's our peak. So after that, guys, we start to lose bone loss of bone density. So this is really for our patients that are at risk. They have to, really understand what's going on, the pathophysiology of the thing. And our patients may have to take hormone replacement therapy, but make sure as a nurse that you are telling the patient the benefit and the risk of hormone replacement therapy. And this one I just put here because I want you guys to remember calcium and vitamin D. Calcium and vitamin D. Make sure that you remember that. All right, calcium and vitamin. That's a heavy hitter. All right, calcium and vitamin is a heavy hitter for osteoporosis. All right. And I put a little examples here for you guys so you don't forget this one, and I'll just let you look at it. Just a visual. Sometimes, most of us are visual learners. All right. And remember, guys, good nutrition and vitamin D. Natural sunlight promotes vitamin D. All right. You want the patient to remain healthy, bone, weight bearing exercises. All right. And vitamin D, vitamin B, vitamin D. Our patients may be at risk if they have any type of parathyroid disease. So I want you guys to also keep that in mind. That puts a patient at risk. And just the last visual for that, so you guys will remember that. All right, guys, last couple of slides, and then we can go enjoy our Friday nights. Now the Friday night will begin after this. So rheumatoid arthritis, okay? Rheumatoid arthritis. Very different from osteoarthritis and osteoporosis. Okay, and we talked about rheumatoid arthritis last week. All right. It's a chronic systemic, remember that word, systemic, progressive, inflammatory, systemic. And look, it's bilateral systemic inflammatory. It's bilateral. It's not unilateral like osteoarthritis. It's bilateral and it's systemic. So this patient feels bad. It's not just a pain. This patient feels bad. Okay. So, and it's an autoimmune disease, an autoimmune disorder. The body is attacking itself. All right. So now let's talk about the risk factors for rheumatoid arthritis. What puts a patient at risk? Female. All right. Age 20 to 50, approximately. Genetic predisposition, Epstein-Barr virus. Okay. Stress, guys, and environmental factors. Put environmental factors. Make sure you write in environmental factors. All right. So that helps too. That puts the patient at risk. Environmental factors. Okay. So what are we going to see? What are some of the signs and symptoms? The patient is going to tell you these things. They're going to say pain at rest and with movement, guys. All right. They're going to complain of morning stiffness, and they're going to complain of joint swelling and deformity. That deformity is the reason why, as nurses, we do a lot of educating, a lot of therapeutic communication. The joint swelling and the deformity can be very severe. All right. Now, systemic. This patient, remember that rheumatoid arthritis is a systemic disorder. So guess what? This patient has anorexia and weight loss. Okay, because it's systemic. This patient has fever and fatigue, guys, and muscle weakness. The patient feels horrible. All right. It's an autoimmune disorder, so it presents a lot differently than osteoarthritis. All right. So what are the diagnostic procedures? What can we anticipate the doctor ordering for our patient? If I know I have a patient who has rheumatoid arthritis, guess what? I'm going to look for the rheumatoid factor. I'm going to look for the ANA. ANA is number 2. ANA. I'm going to look for the ESR. Okay. And I may have to prepare the patient for arthrocentesis. Arthrocentesis. So they'll actually remove some fluid from the joint to study it more. Arthrocentesis. Arthrocentesis. All right. So the diagnostic procedures are rheumatoid factors, ANA, ESR, and arthrocentesis. What are the nursing interventions? What are the nursing assessments? All right. So I have to intervene by making sure that the patient has the medications ordered correctly, 6 rights of medication administration. And these are some pretty heavy medications, guys. So I'm constantly looking for the side effects. So take a look at these medications compared to osteoarthritis. This patient will have disease-modifying anti-rheumatic drugs, guys. So that's methotrexate, leflunomide, and hydroxychloroquine. That's the anti-malarial drug that everyone is talking about. Okay. And these DMARDs have serious side effects. So you, as a nurse, you have to make sure that you're monitoring the patients. NSAIDs, we discussed, and biologic response modifiers. All right. So these are the medications that I have to make sure that I'm giving the patient on time because they do have some side effects, some serious side effects. So our nursing assessment, again, we are focusing on the functional ability. We're focusing on indications of infection. Indications of infection. And we are providing a lot of support, emotional support, guys, psychological support due to the deformities. So your patient Your patient has rheumatoid arthritis. So now the complications that come along with rheumatoid arthritis. All right. The complications that come along with having an autoimmune disorder. So Sjogren's syndrome, guys. This is a triad of symptoms, guys. So this patient, just remember dryness, dry eyes, dry mouth, dry vagina. Okay. So what we have to do for this patient is to make sure that this patient is getting eye drops, artificial saliva. You can even make sure the patient is getting the vaginal lubricants, because just remember dryness, Sjogren's syndrome, dryness, and make sure that the patient is drinking with the meals. All right, drinking with meals. Another issue, another complication that comes along with rheumatoid arthritis is osteoporosis and vasculitis. Okay, so osteoporosis, we have to teach our patient about weight bearing exercises, and for vasculitis, we have to monitor for lesions and even, guys, cognitive dysfunctions. So lesions and cognitive dysfunctions for vasculitis. All right. So just a little recap, just a short recap, a little visual recap for you guys. Rheumatoid arthritis, guys. Remember bilateral, remember systemic, remember deformities. Okay. It can be triggered, or one of the risk factors is if you've had Epstein-Barr virus, that puts you at risk for developing rheumatoid arthritis, Epstein-Barr virus, and warm shower for morning stiffness. So this is something that really helps, guys, because it takes this patient is in pain for a very long time. The patient is in pain for a very long time. So remember morning stiffness, and remember joint swelling. Okay, deformities. You have to be very aware and just let the patient know this is not an expected finding, but this is definitely a clinical manifestation. It is kind of an expected findings, to be honest with you, but you don't want them to just say like, well, don't worry about it, that's expected. This is also something that they have to worry about. Remember the anti-nuclear antibody titer. That's a major lab that we have to pull for the patient. And remember that the patient will do a arthrocentesis. This is a diagnostic procedure. The arthrocentesis. This is a diagnostic procedure to kind of just get more information and to tell the physician. It helps the physician diagnose rheumatoid arthritis as opposed to osteoarthritis. So remember that arthrocentesis. And remember your disease modifying anti-rheumatic drugs, guys. These are some serious drugs. Make sure that the patient is adhering to the regimen. Make sure that the 6 rights of medication administration are always being adhered to also. All right. So remember methotrexate, guys, is a disease modifying anti-rheumatic drug, methotrexate. So pregnancy, make sure that the patient is aware that they have to be on some type of birth control, because we all know what methotrexate can cause. All right. And then we have hydroxychloroquine. This is our anti-malarial drug. You guys know that this thing has side effects from head to toe. So you have to be very, very aware, and you have to make the patient, the labs are required, and you have to see ophthalmologists. The eye exam is very important. And this is Sjogren's syndrome. Sjogren's syndrome. So make sure that the patient is getting eye drops, drinking while they eat. All right. They may even have to get artificial saliva. Vasculitis. Vasculitis is a major issue also. Vasculitis. So make sure that you're doing your head to toe assessment on your patient. And you're also looking for cognitive decline also comes along with this. Cognitive decline. And a complication also for rheumatoid arthritis, guys, is osteoporosis. So make sure that you're teaching the patient about weight-bearing exercises, vitamin D and calcium, okay, and fall risk. All right, guys, that's all I got for tonight. The PowerPoints are there, and I'll put the PowerPoints in the description box for you if you want the PowerPoints. All right. Well, thank you guys for joining me. I appreciate it. All right, guys, make sure you like and subscribe or dislike, whatever it is. All right. And I will see you guys next week. Next Tuesday, guys, I'm having a leadership review. So, just let me know if you want me to send you an invite. All right, guys. Good night. Good night, guys.